Your eyes are open, your heart's open, your ears, mouth, you can talk to the mom and encourage her and all that, but it's really just not disturbing it when it's going well.
You're listening to the Mommy Labor Nurse podcast, where you'll gain the knowledge and confidence you need to erase the unknowns of pregnancy and birth and rock the newborn days like a boss. My name is Liesl Teen. I'm a fellow mom, labor and delivery nurse, and your host. Each week on this podcast, you'll hear a mix of birth stories, expert interviews, and other fun pregnancy and birth-related content. As a reminder, anything you hear on this podcast is not medical advice. Please see mommylabornurse.com/disclaimer for more details. And now let's get into this week's episode. Hey guys, happy Monday. This week on the podcast, I am joined by my friend Anne from Home Sweet Homebirth. Yeah, we're chatting about home birth this week. Home birth is something I am not very familiar with from a practitioner standpoint. I've only ever attended hospital births, but I do respect that some women do choose home birth as an alternative to birthing in a traditional hospital setting. Because of this, I thought it would be really educational and fun to have a home birth midwife on the podcast to talk to us about some of her experiences and answer some of my own questions I have about home birth. Anne has been in practice for over 25 years as a midwife, so she's really seen it all. And today we talked about home birth prenatal care, water births, hospital transfers, and so much more. You guys are going to love Anne and all she has to say in this episode, so let's jump right in. So tell me, are you one of an estimated 80% of pregnant women that's hoping to give birth without an epidural? I hate to break it to you, but simply wanting it might not be enough. After the unmedicated birth of my first son, Walter, I knew I had to create an affordable online birth class designed just for moms that wanted to do the same. And that's how Birth It Up, the Natural series, was born. Learn more about how to make your dream of a natural hospital birth a reality at mommylabornurse.com/naturalbirth. You can totally do this and we can help. Hi, Anne. Welcome to the Mommy Labor Nurse podcast. Thanks so much for being here today.
Oh, I'm so excited to be here.
Yeah. Can you just start by telling our listeners a little bit about yourself and family, where you're from, what you do, all that good stuff?
From Philadelphia suburbs. As soon as I did my nursing obstetrics, I was like, oh, this is what I'm going to do. I went to University of Pennsylvania in Philadelphia, and then I was an OB nurse for several years. And it was my experience being an OB nurse and having my own babies, given the royal treatment though, but in the hospital where I worked with my colleagues, that I ended up deciding to become a midwife. So I've been a midwife for 27 plus years. I graduated in 1995. And I've done, birth out of hospital birth center and hospital birth. And then I have this home birth practice. And so I have 4 kids and I have little 8. They've produced they all were pregnant at the same time at different times.
Are you a grandma now too?
I told them don't ever use that word.
Oh no. Okay. Sorry. I take it back.
I'm like hip hop, I dance. I'm very active and, fun and playful. And I said, you can, so they have 8 under the age, between the 4 of them under the age of 6.
Wow.
And because they grew up with babies in their belly and pushing out babies, and, they tell me my babies breech and, because they grew up on, I had my main office was in my house when I had the home birth, and then they were just into my things, and they just grew up breastfeeding their babies, and so I was at all their births as sort of the mommy midwife. You have mommy labor nurse, but yeah, I said I didn't want to be the actual midwife.
Mm-hmm. Yeah,
I was at all the births except during COVID, whatever. But there's 8 under the age of 6.
Wow, they all live local.
One lives overseas, but the other ones, 40 minutes away. So my house could be a total. You know how it is when you have kids. So my house could be all. Because now since COVID, my office is again in my house. So when they come, it's like they just take apart everything. It's all over the place. And I love it,
Yeah, totally. Totally. Well, I want to talk about first, kind of before we get really into the episode, about your credentials and your training. So tell me kind of what that was like. Because I know here in the United States, there's a couple different kind of ways to do it.
Yeah, well, I am very holistic, and I'm holistic in my approach, which just means using all the modalities, including modern medicine, to help somebody, in terms of healing. Or in maternity care as well. I mean, we need to use whatever works. And sometimes that means modern medicine, right? My training is a Bachelor of Nursing in University of Pennsylvania. And then we have to, in New York, where I live in the suburbs, kind of upstate. And in the state of New York, you need a master's degree. And even if you didn't need it, I'm glad I had it. I went to, it's called Frontier School of Midwifery and Family Nursing. And then it's a master's degree through Case Western University. Yeah. So we have to be master's level trained here.
Yeah, no, that's great. So did you have to do, I'm assuming that was online, and then do you have to do like certain
not everything? No, the clinicals weren't online.
I was going to say you can't do clinicals online. Yeah.
No, we had to go there were I was very grateful for my husband, because I had to go there several times. Mm-hmm. And once I had to spend a month. A lot of the work could be done remotely, but the clinical, once we were starting clinical, no, I'm doing clinical in different sites. I did it in I wanted to get my out of hospital birthing clinical that was done at a local birthing center, freestanding birth center. And then, hospitals local to me is where I did the clinical, and you have to pass the same exams and all that stuff. So when I first graduated, my first job was in an amazing practice. It was a hospital practice, and it was 2 doctors and 6 midwives. And the doctors really only wanted to be involved when there was a high risk situation. A mom is on insulin, or there's triplets or something like that. Otherwise, even those people would benefit from midwifery care, but they would deal with preeclamptic management, or we did vaginal breaches and VBAC and all that, and they called it Dr. Midwife Team Care, because they really feel, and this is sort of the model around the world, is that the midwives, our expertise is in normal, right? Keeping birth normal. And the vast majority of the population having babies are normal and can, of course, intervene. We're trained in all that, how to deal with emergencies. We can prescribe. We can we're first in New York. We could be the first assist at a cesarean birth.
Oh, I didn't know that. Okay,
yeah,
cool.
Yeah. The obstetrician in a lot of other countries is really people like Sweden, for example. They only go to if they're high risk, because their expertise, thankfully, is high risk to treating and diagnosing things very, high risk medically and surgically. And they just don't know they're just not trained. My OB, that is my collaborative OB for many years, he doesn't want to know he doesn't know anything about normal birth. He doesn't know what to do with it. Just give him problems. Like he'll joke with me. He tells my clients, you'll get better care with the midwives, if everything's going well. I don't want to see you unless they're, and then that's the team that I worked with. And when we're sort of in that balance of midwives working with most, the vast majority of normal, and leaving the doctor free to be the surgeon, dealing with complicated problems, then you have this wonderful balance, and we're getting much better outcomes. And that's why the outcomes in other countries are better, when they have this sort of model.
Yeah, I was going to say, because that sounds like a very similar model. I talked to midwife Marley. I'm going to drop her name, but she's a midwife over, I'm not sure if you follow her on Instagram. She has a great page too, but she's a midwife over, I think in the UK. And she talks about similar things. That's just the model of care. They try to keep the majority of patients under midwifery care. And then the high risk patients really should just go to obstetric care.
What we're seeing in the States is when the high risk management is applied to the normal, we're getting high rates of intervention and cesarean and rise in mortality rate, mother's babies, stuff like that. So yeah, it's a big deal, but I love I'm fortunate to work with wonderful doctors who are supportive of this and like this sort of model, but it's, you have to look for it. It's not everywhere.
Totally, totally. Well, let's talk a little bit more about your practice and like kind of what you do right now. So do you see, I know it's a little bit different. Obviously you said with COVID stuff, it's just different than it was pre-COVID. So you're saying you worked before with that practice with those patients and now you're in a home birth?
I started my own practice with a colleague of mine who was actually at that time a doula, then became a nurse, then became a midwife. So we were together in partnership for a long time. And then we just parted in terms of being in the practice together. And I worked with different other midwives. And then I became sort of it was a midwifery hospital practice. And it was like a center. So they had chiropractic care, they had acupuncture, childbirth classes, they had, a physical therapist, an acupuncturist. It was like a holistic center for women. And I was the director of the home birth department. So anyone that wanted a home birth would come to me and my team. I had another midwife and assistants and if they needed to transfer, it was a seamless transfer to the hospital midwives, the hospital or their obstetricians. And then when Obamacare hit and a lot of these hospital practices were, private practice was like sort of bought out by these corporations, and the corporation didn't want home birth in their whatever. The midwives had no control. And so I worked with the midwives in hospital practice for a while. And then COVID hit. And I also work in a local hospital practice, actually, that is mostly a practice of immigrant patients. They don't speak any English. Many of them, they just come over from Latin America, Haiti, and they just have no insurance. They're not legal, right? So I love working with this population, and so I would do shifts there. But my main focus was this home birth practice that was like my baby. I started in 1997. And it's just, been in different places, but we're still serving the families that want home birth. So, so I had two offices. And then when COVID hit, everybody was working remotely and it was too much to keep up my rent. So I just kept my home office. That's what I've had. Yeah.
Yeah. I love it. So I want to talk about like prenatal care. So do your patients then come to you or do you go to them?
Yeah. Okay. A mom having a healthy pregnancy never needs to see the doctor. So we do prenatal care is huge. And we're not just screening. Yeah. We do all the, my first visit is 2.5 hours and a lot of it is teaching, right? And going through their entire holistic health, not just all their, medical, surgical, gynecological, social history, but, how they deal with stress, how they eat, how they exercise, what they love, how they relax, just like answering a lot of the questions for the tests that we do. Some we have to do, CBC is not elective, right? That's just like, certain things are not elective, but a lot of the genetic testing and the screening downs and all that. So sonograms, we talk about all this and then help them with whatever they're dealing with. So somebody, might be dealing with nausea or they're getting frequent UTI, urinary tract infections or whatever it is. And like I said, I can prescribe. So I draw all my blood and do the pap smears and cultures in my office. And if they do, there are those who only want one ultrasound. There's a few that don't want any. And I respect their, right to informed choice. But I would say most people have one, and I'd say mid-pregnancy, unless, 18 to 22 weeks, unless there's an issue. And I just write the script and they go to like my perinatologist does really good ones. But yeah, and then we do a full exam and then they come to us every 4 to 6 weeks. And those visits are an hour. And it's really about getting to know each other, getting to trust each other. They need to feel that they can be totally uninhibited and naked and puking and pooping and doing whatever sensual and whatever they need to do. And trust me that they feel safe, right? And I need to know how to help them best. Some people like a lot of people around them helping them, and some people really want privacy. And, it's that relationship that's so important. That's why, like all these people, when COVID hit and, they're like 35 weeks going to a GYN and they're all wanting to switch to home birth because like not first baby at 35 weeks. You need to have this relationship. We need to help, like, especially for first time vaginal birthers, we need to do a lot of preparation. They're in the West, they're in their Western culture and expecting, it's a whole different culture, like that's why I love working with the immigrant population as well, because the less Americanized they are, they're just, everyone in their area is where they came from was birthing at home. It was part of life. They're used to hardship. They're used to pain. It's not a big deal. They just come and they birth. It's part of family life, right? But the more Americanized they are, the more they're on the media, the more they're Googling everything. We have a lot more preparation to do and, help them get out of their heads and more into their bodies and yes, mindset shift in terms of the pain and all that. So yeah, so I read for all first timers, we require childbirth, classes. I have my online ones, but a doula or a doula-like support. And then, yeah, as it gets, 28 weeks, it's every 2 to 3 weeks, and then weekly at 36. And those visits are an hour. And then we do one home visit. So make sure that we know to get to the house. And
I was going to ask about that. Like, how does that work? You just show up and it's a surprise, or do you? Yeah, that makes sense that you would go to their house first.
We have a whole list of supplies that the family has to get. So I carry in my bag things, some things. Quite a heavy bag. I have like the PPV and the Doppler and I would say the medical supplies that are not disposable. And then the, emergency medications, things like that. And then they have a list of equipment so it's like they will have, and I check at the home visit, we go through the whole list. It's basically the same equipment that an out of hospital birthing center would have. Right. So,
Gotcha.
So it's either for mess control, for comfort, and the disposable medical supplies. And we just go through the list. We set it up on a table or a dresser. They may or may not want to have a birthing tub there, or they have their own tub that they can use. And so, and we know, we just look around the kitchen. They give us where things are, and we tell them how to set it up. And then it's all ready so that when they go into labor and they, then they let me know. We have a whole, way of how to contact us and what's an emergency or when I want to be woken up in the middle of the night, all that when we can it could be just something in the morning. And then we go when we're needed to go. So that's different for each person. And we're there, we do intermittent fetal monitoring. So I'm checking the fetal heart rate and active labor every half hour, and then every 5 or every other push in the second stage of labor. And most of the time it's just, I'm assessing their vital signs, and I'm watching, but most of the time it's the more I do it, the less I have to do. The best intervention when it's working is nothing.
You're stepping back. Yeah.
That's why Michel Audin, as an obstetrician, said, he said in a conference of like 500 midwives in his French accent, the best intervention at a birth for an attendant is to knit, KNIT, because it's this calm presence. Healthcare providers, we have to be busy. We have to be fixing our hand. What do we?
Right.
No, knit. Get your hands occupied with something. But you have this calm presence. You've seen 1,000 births, and when you can put down the knitting. But your eyes are open, your heart's open, your ears, mouth. You can talk to the mom and encourage her and all that. But it's really just not disturbing it when it's going well.
Yeah.
And it's a very, peaceful, there's humanity in it. It's sacred. It's fun. We laugh, we dance. It's very, most of the time everything goes well. And it's just part, kids could be walking around, grandma's taking care of them. But, sometimes the kid will come in front of the mom and like, I want a Red Bull, Mom.
Yeah.
In hard labor.
Because she's still mom. Yeah.
She's still mom. Now, some moms, their labor will stop. So I always say, you always have, and some, the kid can be in their face. Tie my shoes, Mom. And she's just in her zone, and she's just, and we had this one, we've had kids jump in the birthing tub with flippers. I mean, there's and a snorkeling gear. There's a sense of humor. I think the funniest thing was because I do both home and hospital is I had my sterile tray because she was pushing and she had a lot of cats. And somehow a cat jumped onto my sterile tray.
Oh,
and I'm like, can you imagine this happening at the hospital?
No.
I had no time to like get a new tray or anything, and their own germs, nothing happened.
Yeah.
And birth is not sterile, it's their house. And
it's not. Surgery is. A C-section is, but we're not in a C-section. You're right.
We are not doing surgery. Yeah. So then a lot of times people ask me about my transfer rate, my C-section rate.
Yeah. Let's talk about that.
So I would say the most common reason, and this is why I require childbirth classes, is the most common reason for transfer is a stuck, prolonged, and then stuck labor with an exhausted mom. And we have tried everything. And I track my stats, 7%.
I'm like, I hope it's not 70.
No, 7%, which means 93% are doing it.
That's great.
But the ones that are having these long, stuck, prolonged, exhausted labors, it's first-time vaginal birthers who have not prepared. And there are people that just say, I don't need to take a class. And I after, seeing this pattern, I make it a requirement because I want them to succeed, right? Yeah. The times that I've had to call 911, a handful. The most of the time we're screening. That's what prenatal care is. You're screening, you're making sure that we don't have someone on cocaine, right? We make sure we don't have someone with a seizure disorder on medication or insulin dependent diabetes or, hypertension, right? We're screening for 5 C-sections, not everybody can have a home birth, right?
Totally. Right. And that's important to understand too.
Yeah. Not everyone can have a home birth, but those that make it into they make it through the prenatal care and they're in labor, we're not giving them medications in labor, right? They're not being induced in a medical way. And so and they're all healthy. So it's very, unlikely that they're going to have some sort of an unpredictable emergency, but no, things happen like shoulder dystocia. And, we are the EMTs at birth. So the most common, you can't transfer during a shoulder dystocia. You have to get the baby out. They're not, the EMTs do not know what to do, right. The most common emergency that we have for mom is a postpartum hemorrhage. And I carry PIT, IV, Methergin, Cytotec, IV. There are times, that's why I'm so strong on this about not supporting free birth, because I've had situations where
Thank you for saying that. Yes.
If I wasn't there, or an trained attendant, and I'm talking about a physician, because family physicians are sometimes trained in obstetrics, but physician or trained midwife not there, mom or baby would not have lived.
Yeah, I totally agree with you. That's honestly the only thing I can't really wrap my head around and talk about. And really we can talk about it in a negative way, like how it's very, very dangerous, but that's the only thing that I really can't support.
No, and I've told people, because people say to me, I support free birth with me there in the background. As I'm wearing the lifeguard hat.
Just let me be there just in case. I'll be in the closet, right?
Right. And of course, when they're in transition and, calling me. Yeah. But I've had times where dads want to catch and the cord's wrapped around 3 times and then he's calling me. And, so I'm right there.
Right.
But, the most common emergency in a baby is I need to resuscitate, could just be that last bit, the baby's, the baby the head is pressing against the cord somewhere against the pelvis and the baby comes out and is not responding to,
right.
So you need to have recertify an NRP, which is neonatal resuscitation, every 2 years. And that's the most common thing. So if you're going to tell me you're going to free birth, who's going to, there have been times I've had to do, PPV, right? And then, chest compressions. If I have to do chest compressions, I'm calling 911.
Right. You're saying, over there, call somebody. We need somebody here.
Yeah. Right. Most of the time the cord's pulsing and I just have to give baby a little, jump start but there's been, I've had, can't just say I need help in room 3. I've had shoulder dystocia, which then some mild, just and the baby comes out fine. But some I've had to resuscitate, and then of course mom has a postpartum hemorrhage.
Of course, because that happens. Yes.
That's why I always go with my assistants who are trained, or a nurse or another midwife. It depends on the situation, but never lost anyone, thank God, but that's why I support free birth only with me in the background.
In the closet. Right. I agree with you on that. Somebody just at least needs to be, you can do as much as you want. Just let me be there just in case. And I'm saying me as in you, obviously I wouldn't be there, but somebody needs to be there just in the background.
Like if a mother wants to make the choice that it's okay, if I die, I die, but the baby is not in on that discussion. The baby, I'm at least having to advocate for the baby.
All right, the sound of that baby crying means it's time for this week's segment of Birth It Up Babies. Okay, so this Birth It Up Baby is super special because this is actually one of my friends that I used to work with, a fellow coworker, a fellow labor and delivery nurse, and we don't work with each other anymore. She lives across the country now, but she just had a baby and she just sent me her Birth It Up Baby, so I figured I would read hers off. So she says, our baby girl was born in July and my husband and I took your natural series and newborn series. I'm a labor and delivery nurse and knowledgeable about labor stuff, but I still found it so helpful. My husband is not medical and it was so great for him. He knew all of the terminology and was the best labor partner I could ask for. The ragdoll and slackjaw advice was the best. I unfortunately ended up with a C-section after pushing. She was just in there super funky, and then some minor complications during my C-section. Also, our baby was very colicky and had a tongue and lip tie revision. The first couple months were actually really hard, and I referred to your Insta so much. Awesome. I also took the breastfeeding course that you recommended, and that was so informative as well. And that is the Milkology course that she took. Thank you for doing what you're doing. Awesome. Amazing. So happy for you. Yay. If you want to check out this course that she took Birth It Up the Natural series, and you could head over to mommylabornurse.com to check that course out. All right, let's get right back into this week's episode.
I agree. Well, I have a couple questions for you in terms of, no, you're fine. I have a couple questions for you in terms of like when mom goes into labor, how does she contact you? And like, when does she contact you? And like, when do you know? I guess it probably depends on if she's a first-time mom or a second-time mom or a third-time mom. So I have that question. And then I want to know how your schedule works in terms of, like you said, you work with a few different midwives. So are you guys always on call certain days? And like these days you see patients, these days you don't. So let's talk about both of those.
Well, yeah, so everybody is different. My assistant is so good. Actually, she went. You've heard of Ina May Gaskin, yes?
Of course, yes.
Right. So she trained at the farm on how to be a birth assistant, and she is
amazing. I bet she's amazing.
Yeah, and she's also a farmer. So like she's assisted her goats and her horses in labor and all kinds of things. Yeah.
Awesome.
So first of all, for a first-time mom, we really prepare them, and they need a doula or a doula-like support, and that because for thousands of years, women have been supporting women in the home, surrounded by birth, right?
Yes,
so calm around birth, and knowing how to help somebody in that situation, right? So now in the West, we're all spread out, so people don't have necessarily that kind of village of elders to help them. So they need that support. But when they call me, I tell them, don't call me at 3 a.m. that I lost your mucus plug, because I will be up. I won't go back to sleep. That's just me. Yeah. And don't even tell your partner because you need to sleep. I need to be there awake when you're going to need me a couple days or weeks later. Right. So in the middle of the night, I tell first time moms, if you're getting them, if it's early, you can talk, and they're coming I don't care if it's every 5 to 15 minutes, they're lasting 15, 20 seconds. And you're like, you can call me and say, hi, I'm in labor. I'm having one now, so we really go over that.
Right.
Like, don't wake anyone, not even your doula. Try to sleep in between, and in the morning, and you can let everybody know. And then I'll be in touch with her in terms of when to come, but I always encourage them to sleep at night and, rest in the day, but also temper that with, dancing and walking and all that kind of stuff. And for a first time mom who has a doula and is doing well, and I'm on the phone with her, it depends on the distance. I don't take anyone more than an hour from where I am. I like to be there when they're coming every, let's say 3 to 5 minutes, resting a minute or more. And she can't talk.
Right.
She is either, roaring like a lion or she's moaning. And that's usually around the time that I get there. But not everyone fits that, it's really funny. We've had some stories like, so my, here's the situation so we don't do breech at home. That's planned, right? Okay, so this was a first-time mom, and my assistant also is a doula. So sometimes they hire her as a doula, and she knows exactly when to call me, and then she will take on the role of my assistant. And they know that, but they like that there's this continuity, and there's only us there. She called me once, and she said, and this lady lived an hour away. She called me once. She said, this lady, I just got here. Labor just started like an hour ago, but listen to her. And she's going,
yeah.
And she doesn't want me to call you. She doesn't want me to call you. She thinks she just doesn't want me to bother you. It was like 2 a.m, right? I said to her, just do me a favor, because she has all the supplies there. I said, get a glove and just put your fingers up and tell me what you feel. I'm talking her with it. And she says, what she feels is like a 2 knuckles in. And she says she feels something hard. And she feels, but she can only stick 1 finger in it.
Okay.
I said,
no, okay. I know what it is.
I said, okay. Cause the way she was sounding and the way I said, we have a breech. Something in me. So I made it there. And the woman, when I got there, the baby was almost crowning. Right. And,
but not from the crown of the head.
No. The butt was crowning. The butt was crowning and sausage poop was coming out. I said to them both, I said, we have a breech and we're not going to have time to go to the hospital. We're going to have to do this right here. And the dad says, we have a breech. Oh, we can't. Oh my God, there's risks to that. And he starts like Googling it. And she says, get off the effing
Oh
no. Anyway, the baby just slipped right out. That was a precipitous breech delivery.
Wow.
And that's why we have to know those skills, because if you have a precipitous breech delivery with no time to go to the hospital, it's happened to me in 27 years, maybe 2 other times. Like we had a mom who was 41 weeks. She had an ultrasound BPP and the baby was vertex. And of course she goes into labor the next day and she's a multip. I get there when she's in labor, she's in the tub and she starts pushing and everyone's just relaxed and she's on her hands and knees. And what I see coming out is a bag of fluid with sausage inside. Which is unformed poop, poop that has not been mushed up into meconium. It's just like sausage and I'm like, we have a breech. Now this baby flipped in a day.
Wow.
Right. Because she was a grand multip. She is a gravid of 7. So I said, okay, and I've caught the other one. So I'm like, okay, we have a breech. Let's stand up. And the baby just like flew out into my. Right. But planned breech, we wouldn't do at home. So, but anyway, you asked me when we call. So people who have given birth before vaginally, I have to watch them because they can, jump quickly. I mean, I had a birth in my office. People ask me, how often do you have births in your office? I said, nobody wants to birth in my office. They want to birth in their house. So we try to avoid that.
Yeah.
But a couple of years ago, this is, multip. She's in my office. She's 42 and she's, I'm looking at her and I'm like, I've caught her other babies and I know she jumps from early to pushing quickly. And I'm looking at her and she's contracting every few minutes. And I said, how long have you been doing this? She says, for weeks. I said, well, I don't know. I'm kind of uncomfortable letting you go home. I don't usually check unless there's an issue. I said, but I like, mind if I check? And she says, no, but I've been doing this for weeks.
Oh my goodness.
Braxton Hicks. I checked her and she was 9 with a bulging bag.
Oh,
I said, I can't let you go home now. You're, she says, I have to go home. I have to pick up my kids. I have to get anyway, she stood up and then she's,
yep, I'm sure. Yep.
The baby in 10 minutes. But yeah, so I have to watch the second timers because, they think that,
they can go quick.
I'm not going to bother anyone because I was only 1 and they could be 7 and they could just jump quickly. So so I would err on the side of caution and leave sooner to get to a multip.
Yeah, that makes sense. I do want to address that second question that I asked about your kind of call schedule. So what does that kind of look like?
So, okay. So I've been doing this a while. So in the beginning, when I started with my friend who was my doula and assistant and then became a nurse, I was on call 24/7. And, the first year it was slow, but then we were up to, max 4 to 6 a month. That's what I won't go more than that just because I don't want to have 2 people in labor at the same time. And thankfully that usually works out. If not, though, I'm in a community of there's a good amount of home birth midwives that, sister midwives that there's a few that I trust implicitly and we call on each other if we're in that situation.
Nice.
When they sign some documents when they come into us. One is an informed consent. It's very thorough. Another, and it is say that we cannot guarantee that we will be at your birth. That could be, I was out with COVID for a month.
Yeah.
We had a hurricane. Where do you live?
I'm in Raleigh, North Carolina.
North Carolina. It's a hurricane.
We know plenty about hurricanes.
Well. So, we had one where there was no power for 2 weeks. And I didn't hear the news and we had no gas. And, so like there's rare things, sickness. I have missed 2 of my kids' graduations. One was college, one was high school, which broke my heart. So I always, if I have something coming up, I always tell them, I'm going to have a backup for this situation, and I do take vacations. So as I got busier and busier, I used to just say I'm not taking anyone in the due dates of let's say January, and then it became January and February because I just need time off.
Yeah, you're a human just like
my batteries.
Yeah, you're a human just like the rest of us. You can't be always working.
I like to work in a team. I think it's better, because I had a primip not long ago where 60 hours she was in labor, and after I'm up 24, I start to get less and less effective at how I'm thinking and functioning.
Of course. Yes.
When I have another midwife, we switch off, right? So we decide we would be 50-50 on the call and in the office. That's just what we do, right? Yeah. And so everybody who comes into the practice, they can't have favorites. We know that you might like one more than the other, but we're both on the same page, and it's one of us that you're going to get. Yeah, because I also teach yoga and do breath work, so I schedule all that around everything. We'd schedule life around due dates. I have a midwife colleague of mine, a little cynical though. She says, "You want to how to induce someone?" Because she's by herself. Not anymore, but when she was by herself, she got burnt out. And I tell midwives all the time, don't get burnt out. You got to protect your boundaries and work in a team, at least one other. Anyway, she says, how to induce someone? You get really expensive theater tickets, Broadway tickets, and then they'll go into labor. So
she's got a good point there.
Well, so it works the other way. Like if I would be on call and I have expensive Broadway tickets, I tell everyone on call, I have expensive Broadway tickets this day. Don't go into labor. And they don't.
That is too funny.
Call the backup.
No, that is too funny. I want to talk about your assistant though. So you mentioned that you have an assistant that helps you. Is it just one person that you call on, or do you have a few different people?
I have mostly 2, and they're both NRP certified, right? Cool. They both do CPR because that's the requirement, that there should be 2 people at a birth who can do neonatal resuscitation.
Right. And in case mom needs that's how we do it at the hospital too. It's like there's a nurse who's mom and her baby.
Yeah, definitely. I don't understand how midwives do it by themselves. I don't know. Most of the midwives in my area, we bring a trained birth assistant or a nurse. Primips, I have, because that's my transfer rate, right? Primips.
Of course. Yes.
And so I tend, I've seen in my career, once in the hospital, once at home, atypical eclampsia, meaning they were normotensive, meaning 110/70, no protein in the urine, no swelling, no nothing. And then, 15 minutes postpartum, she's seizing in the bathtub. And by the time I had mag sulfate, I started an IV, had oxygen. And then by the time EMTs got there, she was stable. And they in the hospital, they on a straight cath, they got 3+ protein, and they diagnosed her with atypical eclampsia, which is rare.
That's crazy rare.
It's crazy rare. It happened to me because it happened to me in the hospital. I made sure I gave a thing. We have a whole group of the home birth midwives in my area. I'm carrying max sulfate. I suggest everyone does, just in case. Hopefully it doesn't happen.
Yeah. No, totally. That's a good point.
Why am I telling you this? Because you asked me.
I asked about assistance.
Oh, yeah. It's like, I need mag sulfate.
Right. Go get it. I can't do, I'm only one person.
With her, starting an IV, so, she's trained. She knows how to, you get comfortable with who you're working with. And, I know why I was telling you this. Because of some of the things that have happened to me with Primips, I like to bring another midwife when I can for certain ones. So then we have 2 midwives at the birth. Sometimes it's just, most of the time, actually, with the multips, it's all the time, actually, it's just me and my assistant. Yeah. And they might have a doula. They might have their whoever's there. And COVID changed things in terms of that, because when I bring in a transfer, I come with the records. I'm still addicted to paper charting. It's just how I grew up. And I can't.
I'm going to say sometimes when our computer system goes down, it doesn't happen very often anymore because I work days. But when I work nights, every once in a while, they would do maintenance like at nighttime, and we would do paper charting. And I got to say, it is kind of nice doing paper charting. It's very easy.
Oh, yeah. You're looking at the patient. You're not. I was in our local hospital, and the computers went down. We had a stats section, and they couldn't get anything done. They couldn't get any. I'm like, we have to get in the section.
Who cares? Yeah.
They can't get anesthesia. They can't get the blood, the drugs, the medicine, whatever. So I'm very happy with my paper chart.
Yeah.
When I bring a transfer in, I'm calling the local hospitals know me, or if I'm going to where my backup obstetrician is, I'm bringing in someone. We've been, the most common is she's been in labor for this long. We've done everything from A to Z, and we're stuck here. And so I think she needs pit and an epidural or whatever. And they're ready for it's a smooth, sort of relaxed. I go with them. Like if it's before labor, their doula goes with them. Like if it's preterm labor or something, their doula goes with them. But I go with them if I'm transferring labor, and then I bring the chart, and they can copy everything, and I give report to the nurse, to the doctor, the midwife, and then I stay with them until the birth. Yeah.
Nice.
And I have funny stories about that too, but that's pretty much what we do. But with COVID, they don't allow me in anymore, right? So they weren't allowing dads in now or partners. Now they do. Then it was a long time to get the doulas in. Yeah. So there were times where I couldn't go, but the doula could go.
That's so odd. Like, why wouldn't you be like, you're a part of their healthcare team? I know you don't work for the hospital, but that's interesting to me.
So I'd scan the chart and call the midwife, what that's been doing is kind of like me being concerned about taking Primips during this time, unless I can, because I just feel horrible about just dropping somebody off at the hospital. There are people that call themselves midwives, that are not legal. Only a nurse midwife is legal in all 50 states. And we can bill insurance and things like that. And, Ina May Gaskin, people like her, I think they call them CPMs, certified.
Certified professional midwife. Right.
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 Not everybody's like Ina May Gaskin. I would trust her in a minute with my baby.
Yes.
And my life, my birth. But there are some midwives that don't even have that kind of training. See, CPMs aren't even legal in all the states. So
there's some that are just lay midwives and they don't have any, training at all. And it's tough because that seems like, why would anybody choose that? But sometimes you live in a community where it's like, there's nobody else.
They can't afford to pay.
They can't afford to pay, right.
Or they've had 3 sections. They have a risk that no certified nurse midwife would take, So this is what happened to me. I was in the hospital and in comes somebody who has been in extreme pain, and she's 9 centimeters and the baby's in the abdomen. We can't get a fetal heart, and there's a prolapse cord. Oh. And so we rush her back and the baby barely made it, and she needed to be transfused at least 4 bags. Anyway, what happened was her baby was transverse. She had a history of 4 cesareans, and she had what is called a traveling lay midwife that attended her in labor. She said she was in labor for a long time. So I don't understand, no midwife would ever do that at home, or even take if someone's transverse and they can't vert the baby, that's a hospital transfer. You don't get to 9 centimeters with a V, someone's attempting a VBAC like that. So and they all look at me.
Yeah.
Is this what your home birth colleagues are doing? I'm like,
no. They're giving us a bad name.
Right. So one of my colleagues actually reported that to the state because we feel that that's endangering people.
Yeah, totally. Well, let's wrap up this conversation with talking. I'm curious about newborn care and postpartum care. So what does that kind of look like? So obviously at the hospital, you're there for a couple of days, and, the nursing staff and the MDs there take care of newborn, and, we do postpartum assessments. But if you're giving birth at home, it's like, first of all, how long do you stay after the birth? And then do you come back and do newborn care?
Let me just say that vast majority of people have the most beautiful births that are just healthy and empowering, and it's just this experience that they just want to shout from the rooftop, that they did this. I didn't want to just scare everybody off with that other story but that
thank you for clarifying.
Situation. Yes. So in pregnancy, we take out a calendar of about 4 to 6 weeks that we want them to make sure if they don't have a community, they can either get from, sometimes partner can take off for the first 2 weeks, and then grandmom can come, or the mother-in-law, other grandmom can come, or but we want to make sure that they're not on call. They are not. It's not their job. Their job is to rest, heal, eat, drink, breastfeed. That's their job. So no cleaning. Who's going to be doing that? Some people, they don't necessarily have help the cleaning, but that's a good baby gift to put on the registry, right? Help with the cleaning, because it's not on your plate. So we want to make sure they have help with cleaning, childcare of the other kids, if there are other kids, errands, and cooking, meal preparation. So sometimes the church can organize, or sometimes they're in a homeschooling community, or they're some community that their yoga class, or the people will cook for them. There's meal trains and all sorts of things that can be done online. And you can also, for your cook in advance and freeze certain things, we tell them what's good for that. And you can also, that's another thing to put on their registry. They don't need a bunch of teddy bears. They need meals. Or a postpartum doula, so as long as they see who can help with this, like some people will say, oh, my mom is really good with cleaning, but she's very, not good with my kids, or good with my kids, but just not good with cleaning. So then we say, okay, well, how about the mother-in-law? How about your sister, friend, or hired help, or, we work it out so that they have that in place, right? We stay, as long as everything's good, I'll do a full exam on the baby. I like to preserve that sacred hour, right after the birth. And, I'll leave, just kind of watch and let them bond and meet each other for the first time. It's just beautiful. And we'll, be cleaning up and charting and things like that. But then I'll do as long as everybody's stable, baby exam. And we're periodically checking mom. And if everybody's good, we'll leave in about 3 hours.
Okay. Yeah.
With, an ammonia salt.
Mm-hmm.
I leave them with instructions.
Okay.
And ammonia salts. And if it's somebody who definite instructions on checking their own fundus and the uterus and what to do if there's too much bleeding. And I've had great success with herbal and homeopathic remedies for the postpartum. Once we get past the 3 hours, I have
the initial,
I have only once or twice in all these years had to go back and give medication.
Okay.
Then I do 2 home visits within the first 24 hours and then the next few days. And then the baby is like, they need to have a pediatrician. Some of the pediatricians are, they who know me, they're like, bring the baby in a week. But some, so it's up to the pediatrician is responsible for the baby at that point. And the mom can call me anytime there's an issue. We do a 2-week check-in, which has, at least during COVID, has gotten mostly Zoomed. But they're welcome to come in the office. And then there's like a 6-week postpartum visit where, we'll do the whole full assessment and we'll talk about family planning. Some of them want an IUD.
And do you place those? Do you have IUDs? Oh, okay. Okay.
Yeah, it's a great method. It is.
I have one.
Oh, yeah.
Just hard for the TMI, but yes, I agree with you.
Oh, it's a great method. Yeah, especially for, busy moms. See, in the clinic in where I work, a lot of them are not necessarily monogamous, and I wouldn't want them to have the IUD, and they're they're not interested in natural, and they want hormonal contraception and condoms. And the families in my practice, they are into natural family planning, and they'll use condoms or they used to use diaphragms. I think it was hard to get for a while, and now we're back in one. But the IUD, great. Yeah. Very, very popular method. I put them in and take them out.
I know. Easy, right? You don't have to think about it. All right, Anne. Well, this was a pleasure. Yes, I know. Yes, it is.
Right. So if they don't want the hormones, they can get the copper. Right.
Right. Exactly. All right, Anne. Well, this was a pleasure. Thank you so much for joining me today. This was amazing to chat, all things home birth, because I know I get a fair amount of questions and DMs. And I mean, it's tough because I've had people even say like, well, will you do like a home birth, course? And I'm like, I wish I could, but I can't. I don't know enough about home birth to make a whole course to educate these people. So I appreciate you at least coming on here and shedding some light.
I have a whole course. That's my
Love it. Well, anybody who's listening who is asking me that can go to your course. Yeah, love it.
You have the link to it?
I will put it in there. I will put it in the show notes, and then we're going to share this
for hospital birth as well, because a lot of people come to me and they say, like, now we're on Instagram, we're global. Yes. They want to have a home birth like experience in the hospital.
In the hospital,
so possible. That is
so. Thank you for saying that.
In my other practice, so possible. Move in, bring your stuff.
Yeah.
And communicate.
Yes, absolutely. Well, I love it. I will share the link in the show notes page of this episode. And then when I upload it on IGTV, I'll share it there as well.
Great.
So
great.
Yes, this was lovely. Thank you so much, Anne. It was a pleasure.
All right. Bye-bye. Pleasure.
All right, guys, that wraps up this week's episode. Thank you so much for tuning in and letting me be a part of your motherhood journey. It is truly an honor. If you like what you heard, don't forget to hit that subscribe button so you never miss an episode. And I love hearing what you guys think of the podcast. So if you're liking what you hear or you have a suggestion, I'd be so grateful if you'd go ahead and leave me a review wherever you're listening to help more mamas just like you find the show. What do you think? Are you starting to feel a little more confident about your pregnancy and birth? Well, if you want more, be sure to head on over to mommylabornurse.com/podcast for today's show notes and a library of episodes so you can keep getting educated before your upcoming birth. And while you're over there, be sure to check out the blog and learn about our online birth classes. Find it all and more over at mommylabornurse.com/podcast. See you next week, same time, same place.